Okay, good morning, Dr. Burley. We have a quorum.
Okay, excellent. Thank you, Jesse. And good morning, everyone. Thank you for joining us for the Medical Advisory Committee for Monterey County EMS. We'll go ahead and start with introductions. I'm Dr. Burley, EMS Medical Director for the EMS agency.
Teresa Rios, EMS Director.
Morning, Deborah Hopgood, Management Analyst 3 with the EMS Agency.
Kimberly Hernandez, EMS Analyst, EMS Agency.
Good morning, Jesse Aller with the EMS Agency.
Good morning, Blake Anderson from the EMS Agency.
Steve Brooks, EMS Agency.
Good morning, Tina Nieto, Law Chief. I'm also here with Keith Boyd at Starbucks.
Sandra Flores, Communications Manager, AMR.
Good morning, Christy Sobleski, Chomp Emergency Department.
Noah Hawthorne, Neva Memorial ER.
Michelle Kalinsky, Chomp.
Carrie Cantman, SUMH.
Justin Arias, Monterey County Regional.
Recording in progress.
Good morning, Jeff Warner, Program Director for CalSTAR, representing Air Ambulance.
Ben Hitchcock, AMR CES.
Good morning, Rachel Nealand, MRCS.
Hi there,
Ryan Alexander.
Ryan Alexander, Salinas Fire, EMS.
Okay, anyone else join that we did not capture?
Yeah, this is Dr. Orchard, Natividad, ER.
Good morning, Dr. Orchard.
Close, Chomp.
Morning.
Prescribe safe.
Nick Greenson, Salinas Valley.
Okay, great. Well, thank you and welcome, everyone. Appreciate you all being here this morning. We'll go ahead and move on to the next item on the agenda, which is an opportunity for public comment. Any member of the public may address the subcommittee for a period not to exceed 3 minutes on any issue not on the subcommittee's agenda. MAC will listen to all communications but may not take any action. So any public comment for this morning? Okay, hearing none, we'll go ahead and move on to the next item, which is approval of past MAC meeting minutes for September 14th and October 12th, the AB 361 meeting on October 12th. So hopefully you've had a chance to take a look at the MAC meeting minutes, and unless there are any objections, we'd like to entertain a motion for approval.
Jeff Warner, I'll move to approve the meeting minutes for both meetings.
Thank you, Jeff. We have a motion. Do we have a second?
Ben Hitchcock, I'll second.
Thank you, Ben. And Jesse, we need to take a roll call approval for approval of the minutes.
Absolutely. So I'm pinching for Deborah here, so I'll try to do the best I can. Roll call, Dr. Kalinsky.
I need to abstain from September as I was not present, but I will approve October.
Dr. Hawthorne.
I also approve. Thank you.
Dr. Orchard.
I approve.
Dr. Greenson.
Approve.
Christy Sobleski.
Approve.
Will Hiller. Will Hiller.
I don't think I'm a voting member of MAC, but I'll approve.
Okay, well, just checking. Well done. That was a test and you passed. Jeff Horner
Aye.
and Chief-elect Tina Nieto.
Aye.
Is there anybody that I missed?
This is Ben Hitchcock. You missed me, and I approve.
Thank you, Ben. I got you.
This is Carrie Campman. I was not on there, but I need to abstain because I was not at the September meeting.
Thank you, Carrie.
Okay, thank you, everyone. And so with that, the meeting minutes for September 14th and October 12th, MAC AB 361 special meeting are approved, which brings us on to correspondence, which we have none. And that takes us to reports and an EMS agency update from Teresa Rios.
Oh, she's muted. She's
Looks like
talking.
you're muted, Teresa.
Oh, sorry, I double muted myself. Thank you, Dr. Burley. In your package, you'll find a staff report as usual with highlighting some of our recent activities, progress on some long-term projects, and also anything, that highlighting some new projects that we are working on. You'll notice that there's a couple of projects that we are going to have to put on hold. We have a lot of competing priorities. These two projects have been difficult to move forward. And so I think we need to go back to re-strategize, reassess how we move forward. If we do move forward, I think we need to talk to some of our stakeholders again and just to make that assessment. But I'm happy to answer any questions regarding any of the items on the staff report.
Any questions for Teresa? Okay, they'll bring us on to MOAC activities, and Deborah Hopgood has a report for us on that.
There is a staff report included in the agenda packet. Just highlight a couple things. As far as the COVID and Mpox data goes, there's been no significant changes since the report was written. I'll highlight the end of the state of emergency, which Governor Newsom has announced for February 28th, 2023. The EMS agency and the health department are both analyzing the impact that that change will have on our current operations, and we'll be putting out more information as we've had more of a chance to review that. The other change that I'll highlight is that EOC Logistics will be limiting the pickup hours available for PPE and testing supplies. So there will be more information coming out about that for those of you who are still requesting supplies. And for those of you who are interested, I would point out the information on the Ebola virus within the written report as well. So happy to answer any questions that anyone may have about the report.
Okay, thank you, Deborah. The next item on the agenda is a report regarding ambulance patient offload times, and Kimberly Hernandez has that for us.
Good morning, everyone. There is an APOT PowerPoint with the numbers for September and August in your agenda packet. APOTs remain stable. We continue to report APOT weekly to all the hospitals, and I'll answer any questions if anyone has any.
Great, thank you, Kimberly. The next item is old business, and the first item on the agenda for that is law enforcement requests related to blood glucose, jail, and medical checks. Deborah, that's you.
And I'll take that one in tandem with item B, disposition of intoxicated persons. As Teresa alluded to, we have been diligently trying to move these two efforts forward in tandem for several months now. And we've encountered a variety of challenges. We most recently met with our law enforcement partners and discussed the programs with them, heard their feedback, and have some more challenges and issues that would need to be sorted through. Based on the number of challenges that have arisen, the delays in implementation, and the other variety of competing projects that you'll hear about later going on. We've decided to table these 2 items for now. They may be revisited sometime in the future, but they have been delayed, at least at this point, if not canceled.
Okay, thank you, Deborah. And will we keep those on the agenda for future MAC meetings, or should we remove those from the agenda moving forward until we have any progress or change in the status of those?
I would recommend removing unless they should come up at some point in the future for new consideration.
Okay. Thank you for that. That moves us on to a LOSOP for blood and blood product transfusion monitoring. And that's you as well, Deborah.
Yes, and we are continuing to move forward with this project, currently working on education and LOSOP application development. More information to follow in the future.
Excellent. And that brings us to MAC membership updates, and that's you as well.
Yeah, no significant changes to report since the last meeting. We have continued to reach out to the Fire Chiefs Association for their nominations for a couple of open positions. We're also continuing to seek to recruit a paramedic from AMR to serve on the committee as well. So still in progress.
Okay, thank you. Triage tag days with Steve Brooks.
Yes, good news on this. We are moving forward with the triage tag days. In fact, they're coming up next week. There'll be 3 days where every patient, except for those who on the training materials were listed as not receiving a triage tag, will receive a triage tag, and we'll work on familiarizing our field personnel with the triage tag, and also eventually work on tracking patients through the ED. And very excited about this. We've distributed training materials, both for instructor-led type of training as well as individualized training. Same material, just one set up in a PowerPoint, the other set up as PDF that the individual can review, and also see the instructor notes that are included with the PowerPoint. So we just need to, last logistical item, I believe, is to distribute the replacement triage tags to AMR so that they can ensure that people don't deplete their supplies as they get used.
Hey,
Excellent.
Steve.
Yes.
Hey, this is Christy Selesky from CHOMP. Would you be able to provide me with the dates that we're going to do triage tags? The reason I'm asking is our patient access would like to be involved with trying to put the triage tag number into the registration. That way, in the future, if there is ever a need to actually use this, we will have access to the triage tag number in their registration. So they'd like to upstaff for that, but we need to know the dates ahead of time.
I believe it's Monday, Tuesday, Thursday next week, but I can definitely send those dates specifically to you when we're done with MAC.
Wonderful, thank you.
Okay, great. Thank you all. The next item on the agenda is the ET3 implementation, and Kimberly Hernandez has a report on that.
So not much of an update since implementation and since what we updated in September, other than the number of patients that fit the ET3 criteria that actually use ET3 or elect to use it is quite low. In August and September, which it started, it was implemented in August, there's been a total of 4 ET3 patients. Again, the majority of the patients that fit the criteria decline the ET3 option. And Ben is on the call, Ben Hitchcock from AMR, if he'd like to add anything on his end.
Yeah, currently what we're doing to try to figure out why people are a little less inclined to use it is I'm actually getting ready to deploy a survey to patients that fit criteria but did not opt to use the option. We still survey out all the patients that that meet criteria and choose to use the option. And in addition to, I'm also actually today about to deploy a survey to our field crews to see if there's any room for improvement in the program that they can see.
Thank you, Ben. And I also wanted to add that Dr. Burley is QAing 100% of all the ET3 calls, and if you'd like to add anything to that.
Sure, thanks, Kimberly. And just a comment, as in terms of utilization, I think this is common, similar to what other jurisdictions have seen with implementation of the program. Usually the interest and willingness to utilize the program is fairly low at the beginning, and it tends to improve as time goes on and people become more familiar with the option. So not too surprising in that there's been a small number of cases, kind of what we expected. In terms of QAing the cases, as we already mentioned, there were only 4 cases that came across my desk, and I took a look at each of them. In general, the utilization of the program has been appropriate, and I am providing feedback to AMR on each case as warranted. So that process is going well as well. Any other?
Thank you.
Sure.
Thank you for setting that up. I really appreciate that you're looking those over.
Absolutely. Any other questions? No comments? Okay, excellent. Well, the next item we have is the 2023 policy and protocol review cycle, and Steve Brooks has that.
Yes, for the review cycle, we have received the public comments. The EMS agency staff has reviewed them, has made appropriate adjustments to the policies and protocols based on the comments, and these have been put out for review. They're available on our website. Have also been sent out to pretty much anyone who's ever expressed interest in receiving those. And we've set up 3 meetings next week. I believe these are Monday, Wednesday, and Thursday to have an hour available of EMS agency staff time for anyone who would like to join us by Zoom, where we will answer questions related to the policies and protocols that received further revision or didn't, or whichever way, but had received public comments. So the agency staff will be available for a couple hours next week, 3 separate meetings to hear any questions and answer those questions for anyone who's curious about how things developed. And then after that, we'll be refining to bring to MAC in January with the public comments. That's the next big step.
Okay, well, thank you, Steve. Appreciate everyone's work on that big process and project, and so far it seems to be going fairly smoothly, and we'll look forward to its continued progression along the way. Let us know if you have any questions or concerns. The next item on the agenda is impedance threshold devices, and Steve, I believe that's you.
It is. Just a real brief comment. We know there's interest in utilizing this device. The EMS agency is looking to do a bigger project related to resuscitation, in which this would be a piece of it. So it'd be premature to move this forward while we're looking at the whole of resuscitation. So for now, the impedance threshold device is essentially tabled as we work through the bigger picture of resuscitation.
Okay, thank you, Steve. Next item is a LOSOP for buprenorphine administration in the pre-hospital setting. And Jesse, that's your item.
Awesome. Karina, would you mind pulling up the PowerPoint 7? And I'm going to tag team this just update presentation with Dr. Close, who's also on, but I'll go over this PowerPoint. I think there's 6 or 7 slides just to give you a quick update on this project. Oops. That's not that one.
The one?
Number 7, I think it was at the top.
I'm sorry, what number was it?
The one at the very top, number 7.
Yes, it was that one with the stethoscope.
Yeah.
Awesome, thank you. So there's a little QR code on this. If you take your phone and scan it, you could pull the slides up. There's only about 6 or so, but it will give you access to that slide deck. This is a Tri-County project. We're working with Santa Cruz and San Benito. Dr. Gilladucci is representing and Dr. Burley is representing Monterey County. Next slide, please. So just a quick update, we have developed an aim, and I'll kind of go over that, both a process measure and an outcome measure of what we want to do with this LOSOP. We've developed a driver diagram and a timeline, and some of this is really over the top, but this project started as a pilot project. So we kind of really took some time to develop some strong project management pieces behind it. This has now become a local optional scope of practice. And I'm being told that 15 other LEMSAs in the state of California will be applying to the state in December, like we have. Fortunately for this project, we're the first one, so our application is at the top. And because of that, there's some funding that CDPH and Dr. Close and I had a meeting with CDPH yesterday, and there's some funding that may be available to this project, which would help for rollout, training, et cetera. So we're kind of excited that we have taken the first lead on this. We've set up a timeline. So we did submit our application to the state, and then we have developed a draft treatment protocol. Next slide, please. This is our process measure. We want to start this project by April 1st of next year, which has kind of been our goal. And then once we get going, we'd like to, for the first year, this is our outcome measure that you can see, kind of work out some of the kinks, see what, appreciate impact, appreciate cost, appreciate call volume, et cetera, and then really refine our process, and then open the side to other providers countywide. Next slide. This is kind of a picture of buprenorphine. It's really small, kind of looks like a Listerine tab if you haven't seen it before. We're working with AMR on even where to put this drug on the ambulance. So it's kind of exciting. Next slide, please. We have created a few committees. There is a community consortium which meets every 6 weeks. This is kind of an overarching committee of this tri-county group. It involves many players from all 3 counties. We have a steering committee, which is kind of doing the lion's share of this work. They've been meeting every 2 weeks. And then we have some committees that report to that steering. The SUN group, our substance use navigators, our IT, or what we're calling a data analytics group, and then a financial group, because there's some funding that's available. We felt it prudent to meet together as a group. So it's very structured, lots of things happening. We're working on it every day behind the scenes, and it's very exciting. Next slide. Here's just kind of a picture of over the next few months, some of our timelines, some of the things we've been doing, meeting as a group, et cetera. And then we are going to release a memo today. It was in this packet. It's also an EMCC. We're limiting this project to AMR paramedics only at this time. We do anticipate opening this to all ALS transport providers. But again, we really just want to study the cost, appreciate the utilization, the effectiveness, and work out some of the kinks before we open this up to others. And we'll send that memo later today. Next slide. Dr. Close, would you like to add anything that we missed or just give an update? I know you've kind of been leading this project, so you really should have been the one presenting.
No, you do such a beautiful job in getting all of this put together so nicely and so well organized. I'm so grateful. Yeah, I'm here obviously to answer any questions, to see if anybody has any thoughts or any suggestions. I do want to mention, Teresa, I actually had a meeting, I guess, it was Monday, with Elsa And I mentioned this to her as one of the things we're working on. We had been talking about gaps and how we're trying to fill them and then what funding may be needed in the future. So she asked specifically if we had been communicating on this. So I let her know that we were working through this avenue, obviously with Jesse, making sure everything stays nicely organized and in alignment. And then the other thing I wanted to mention, I know there's been a lot of conversation about First Watch and OD maps and notifications, and what Contra Costa has done and what our intent is to do is to work directly with First Watch. This isn't part of an OD maps project and they're completely separate. This is really in direct communication with the substance use navigators in order to connect patients to care. And so I know there's been some concerns about how we're moving forward with OD maps, and that is 100% separate from this project. So I wanted to make sure that that had been addressed. And then truly, I'm here to answer any questions and to help in any way that I can. So I want to thank you, Jesse, and thank you everybody for this time.
I had a question, Justin Reyes from Monterey County Regional Fire. And this might be more for the EMS agency, but being that we're also a transport agency, will we be required to be part of this implementation?
That's a great question, Justin. So at this time, we're limiting this project to AMR, at least for the next year. We want to work out some of the kinks. We want to appreciate the cost. We want to look at utilization. We want to QI the heck out of it, make the treatment guideline even better. And at that point, then we're going to kind of make a decision. Is this, something we want to open up? We anticipate, but we'd like to reserve that decision to see if we want to open this up to other transport providers. And we think we will, but we want to kind of step one.
Okay, no, that sounds good. And just want to confirm though, that this is not going to hinder on any of our auto or mutual aid responses to AMR then, being that we won't be able to provide that service into their first in area?
No, this will
Okay.
not impact that.
All right, thank you.
And I believe it was Dr. Orchard that asked last time when we were talking about this of the utility of administering buprenorphine in the field. And it was something that has been very clearly described by those that are already doing this work, is actually kind of like you give Zofran when somebody's horridly nauseated or vomiting in the field. It's a similar relief of suffering that we're offering. The fact that it in addition helps people potentially start that road to treatment is truly in many ways an added benefit. But that I did want to directly respond to that from last time, because as I talk to more people in the field that are doing this work and ask them about it, that's really how it's seen, as truly relief of suffering with the added bonus of connection to treatment. I hope that helps.
Great. No,
Yeah.
definitely. Thank you. Thank you.
Thank you.
Excellent. Any other questions for Dr. Close or the team regarding this LOSA? I just wanted to again extend my appreciation to Dr. Close and Jesse and Dr. Ghilarducci, everyone who's been involved in moving this forward. It's been impressive to watch, Jesse, the degree of organization that you brought to this project. And so excellent work. And thank you, Dr. Close, for kind of bringing this to our attention, and Dr. Herman and helping us to get on board with this, because I think it's very worthwhile and I think it'll benefit a lot of people. So thank you again for your time.
Oh, thank you. And truly, if Jesse hadn't been so on the mark and making this happen, we may have missed that CDPH funding. They're only funding 3 sites. And we are in those 3. So kudos to Jesse. Thank you.
Okay, well, if there are no further questions, we'll move on to the next item on the agenda, which is EMS Authority updates to guidance regarding COVID-19 and influenza testing and vaccine administration. And Deborah, I believe this is your item.
Is the EMSA updated their regulations related to vaccination administration, and we subsequently updated our policies. Those were recently out for public comment. The update is that we did not receive any public comments during that period, and the current policy will remain in place without any changes due to public comment.
Okay, thank you, Deborah. The next item is Health Data Exchange implementation. Kimberly, you have a report for that?
Yes, so Health Data Exchange, we have been, we're working with me to get a kickoff discussion set up with ESO to start implementation. Natividad, we are still in discussion with them or corresponding with them about the right people to get onto the kickoff discussion. And the same with Chomp. Chomp reached out to us after the September meeting and put us in contact with a more appropriate person to start the correspondence with. And so we are corresponding with them and trying to get a kickoff discussion scheduled.
Okay, thank you, Kimberly. The next item is MAC bylaws cleanup, and Deborah, that's your item.
Yes. So included in the agenda packet is a copy of the current policy 1020 EMS advisory committees and the draft version of the changes that have gone out for public comment and are currently scheduled to go into effect on July 1st, 2023. So as you can see from the current policy, the bylaws are included within that document. And they also state that EMCC and all of its subcommittees are subject to the Brown Act. Several problems related to that, including the increased requirements at their places, and then also that our QI related committees are included in those group of subcommittees, which create obvious problems related to confidentiality, closed meetings and that sort of thing. So we've conducted a review of the regulations and other LEMSAs, and we've identified that the only committee prescribed in the regulations is EMCC. It is required to be appointed by the Board of Supervisors and subject to the Brown Act. Our other groups, the subcommittees, are ones that we can appoint and we're not required to be subject to the Brown Act. So if they weren't subject to the Brown Act, this would cause some effects, such as we wouldn't have had to have the AB 361 meetings for MAC and Ops. And then we also would be able to continue meeting remotely for MAC and Ops once the state of emergency comes to an end. So what we are proposing to do, as you can see from the updated policy draft, is updating the policy to remove the bylaws and make them into their own separate documents, complete a review and update of the bylaws as they would be their separate documents, and then remove the requirements for the subcommittees to be subject to the Brown Act, leaving EMCC as the sole committee subject to the Brown Act. So our process that we are proposing to follow is to provide you one with this kind of introduction to the process and our changes at this meeting, and then come back in January and seek endorsement from the committees to make the changes, removing the Brown Act requirement for the subcommittees. Complete a review and cleanup of the bylaws. We've noticed over time, by including bylaws in the policy itself, they have somewhat drifted from what the board approved. So we have kind of two sets of competing documents at this point that we need to bring in line. We would then take those changes to the Board of Supervisors for approval, and then have the changes, including the new bylaws, ready for a July 1st implementation date alongside that new policy. So I'm happy to answer any questions about that, but that's what we're proposing at this point.
Okay, thank you, Deborah. That brings us to new business, and the first item under new business is behavioral health destination and policy 5000. And just a general discussion regarding that. Teresa, do you want to maybe sort of introduce this and you know, kind of bring us into the discussion?
Yes. Thank you. I was just unmuting myself. Thank you. I would like to turn it over to Dr. Kolinsky. She contacted the EMS agency requesting for this item to be placed on the agenda, and so that I don't misrepresent what the discussion maybe, or what the reason why she wanted to be placed on the agenda. Maybe she can start us off.
Sure, happy to. So a lot of you guys already know what's been going on in the background, but for those of you who don't, or who haven't been in the system very long, we have 2 behavioral health receiving centers in the county. And patients similar to STEMI, trauma, and stroke are preferentially sent to a facility that has behavioral health capacity. The difference is that the two facilities have vastly different capabilities, and that one is a secured locked facility that can take care of patients who are potentially violent, combative, or a flight risk. And the other is a completely unlocked facility, but with fairly vast medical capacity. So whereas a lot of locked units won't take somebody with an IV or medical issues, our facility manages fairly complex medical cases and a lot of, well, in the past, anybody who's been here for a long time knows that there used to be a split branch for behavioral health, and that geriatrics, and we at one point had an adolescent inpatient capacity, would come to us, and kind of violent, combative, flight risk patients would preferentially go to Natividad. We switched that when we lost adolescent capacity, and realized that at that time we were able to move and kind of discharge a large number of patients, and we felt that there was too much ambulance traffic going back and forth, and it would be better system-wise just to keep them in the catchment area. More recently, that's become a larger issue because it's difficult to find a location to move a patient to. We have no ability to house, admit, or take care of violent, combative, flight risk patients on an unlocked unit. Yet they're preferentially coming to us. And if I go through the 1,000+ cases that are coming within the system, many of them are coming from really borderline catchments. A lot of times it's Marina, and the distance is actually shorter than Natividad, but the drive time is actually shorter to Chomp. And this is having a huge impact. We've been informed by the EMS agency and AMR, and this has been an ongoing issue. Our transport times to get patients out when we finally do have an accepting facility are significantly delayed. There are times where for behavioral health, there is no place within a 3-hour range. We've now been informed that AMR can no longer support interfacility transfers out of patients over a 3-hour range. We've also been informed that there'll be a 24-hour notice. If you can think of the impact that holding patients for days on end in the emergency department has on the patient's well-being and mental health, you can probably recognize that this is part of the reason why patients are also getting more and more and more combative and requiring the locked facility, because this is just a lot of times becoming rather inhumane. It's clearly a nationwide issue, but as a county, as I was talking, this is having a big impact on AMR. It's having a big impact internally, and it's having a huge impact on patient safety to go back and forth and medic safety to go back and forth between facilities. And my thought is that maybe it's time to revisit what we did in the past, which was direct patients to the appropriate level of care and appropriate kind of facility that could care for their comprehensive needs. And in that case, we would need to have a filter that someone who is violent, combative, and in restraints or a flight risk would not be preferentially sent to an unlocked facility that didn't have the capacity to care for them. I've gone through our data, and in fact, we end up discharging a lot of these patients, but the reality is we end up discharging these patients after 3 days, 7 days, 10 days, or 30 days. There's a patient that basically could have occupied every bed in my department for 14 hours that came from a mileage distance that was closer to Natividad, is attached to county resources and is followed by county mental health, has no attachment to Chomp. And it just seems kind of like, if we know that we're impacting the system, we're bringing AMR back to move these people. Sometimes we're moving them huge distances. Sometimes we're not even going to be able to move them within our system, right? We don't have a transfer arrangement outside of what was agreed to in the RFP so long ago. It's not like Chomp has a transport service available. We may have to incur the costs of doing that for these longer transports. But if we could have taken this adult patient to the county hospital where she has her resources and she has her care and is closer to her board and care facility, it would have relieved a whole lot of pressure and given you guys better access too, because your wall times are going to go up as I'm boarding more and more of these RSV and other respiratory people in the department as well. So I briefly mentioned this at our meeting with AMR and the EMS agency in June, is maybe we should revisit optimizing and getting some of these patients to the right place the first time, kind of decreasing the patient and medic safety risk of a double transport and helping alleviate the stress on a facility that can't take care of them. The other group that I see a problem with that's preferentially coming to us that really isn't mental health is we're getting a lot of direct transports for behavioral health issues, but it's tox related. So it's a methamphetamine who's combative. And these patients are similar to the intoxicated alcohol patients. They just need to metabolize. They're not getting behavioral health or psychiatric services a lot of the time. So I don't know. To me, it seems like some of those patients may be able to even go to a non-psychiatric facility and go someplace where there's chemical dependency resources. But those were our thoughts, and we didn't know what the rest of the folks thought. But as I was talking to Ben and Will and saying, what do you think AMR wise? This seems to be having a big impact. They said, maybe we should take a look at it. And that's why I brought it up.
Yeah, this is Dr. Orchard from Natividad. I do want to acknowledge that this is, the mental health crisis is real, and it affects everybody's ER and throughout the nation. So I don't think just because you're a behavioral health receiving center, you're the only one having that burden. And I would say if they were, the patient was a differentiated patient in the field that's combative and at risk for danger to themselves or others, then going directly to that location could help. But a lot of these patients, as you said, are still undifferentiated. They are, could be from polysubstance abuse or whatnot. And it's hard in the field to differentiate that without having time to metabolize and have a further proper workup. And so preferentially directing patients to, say, Natividad, when we're all struggling with resources and we're all strained with staffing and resources, would put, I think, have the potential to put a negative impact on all the other patients that we care for. I mean, as it is, we probably see around 7 to 8 patients on a 5150 a day. And those patients are very staff and resource intensive. And that takes up about, 40% of our beds in the ED for over, 12 to 24 to multiple days at a time, prior to even getting into our behavioral health facility. So,
yeah. You do understand that preferentially these patients are being differentiated in the field, and they're not going to two facilities in the county already. So SVMH and down south are not picking up these psych patients or patients.
Yeah, correct. But I would say, a person who's needing restraints on a 5150 are not always purely, like you said, purely psychiatric issues. It could be polyfactorial. So I think a lot of, majority of ERs have that capability to take care of those patients, stabilize them, kind of work through what's going on, and then get them to the appropriate place.
So perhaps within the system, then what you're suggesting is not necessarily differentiating those patients in the field that are not clearly psychiatric only, depressed, suicidal, and sending them to the closest receiving center for evaluation and stabilization. Is that what you're suggesting?
No, I'm just saying, I think a lot of the other ERs, they can stabilize those, acute agitated patients, because you do not know exactly what's going on initially. I mean, some are clear, but, majority aren't.
Okay, because right now those patients are being diverted away from potentially closer ERs like SVMH or me down south. And I wasn't even considering that in this. I was more considering, those true kind of diagnostic. And when I went through the database, there's a significant number. Again, I'm sure traffic wise, we would have been a couple minutes closer. But these are people fully attached to the county facilities and closer mileage wise and violent and combative schizophrenics, not intoxicated, coming out of their board and care, no longer safe. And there's no way we're going to take care of them. And they've already been trying to medicate them for days when they put them on the hold. And I'm not sure why they're directing, away from a locked facility. It seems like a double transport, double issue. Those people aren't going to get better. I mean, for us, at least one of them stayed for pretty much close to a month with nowhere to go in a closed ER, and was actually well within, depending upon if it was morning or afternoon, the catchment area for Natividad mileage and kind of time wise, the majority of the day, depending upon what time you were driving. So I don't know. I don't have a great answer for it. It just seems to me that we're taking people into an unlocked facility, not allowing a timely transfer out. And you're right, it's a nationwide issue that's a mess. But I'm not sure. Frequently, I'm over 7 a day coming in. And we have essentially 8 to 12 beds solely dedicated to this reason. Every single
I mean, yeah, we have,
like you guys do.
so if you have 7 to 8, if we have 7 to 8 a day and majority are staying, over easily the average is 18 plus hours. So I think you're seeing more than they're taking up more than, 7 to 8 beds, correct? So we have 19 beds. If it's only, 8 a day and there's not overlap, that's still 40% of our capacity, of our bed capacity. So,
Yeah, so
and,
maybe
and,
we
and when they're just coming direct, if you're, ideally, if the patient was differentiated and you knew exactly what they need and they need to go straight to our lockdown behavioral facility without any of that, time to differentiate, then yeah, but there's also limited beds in that facility as well, limited resources. And that's not the ideal situation where they come to our facility and go immediately to our lockdown facility. Our turnaround times to admission are 16, 17 plus hours. So they're sitting in the ER prior to getting up there.
Mm-hmm. So, in terms of your recommendation or your consideration for those patients that are undifferentiated that can be stabilized and cared for in any ER, what were you thinking with that?
I just think having a filter that preferentially just goes to Natividad specifically, because I'm biased, because that puts undue stress on taking care of all other patients. It would make it potentially a lot more difficult. So I don't have an answer.
Hey, Nick, I think you're on. What's your guys' thought about receiving some of these undifferentiated, a lot of times chemmed up type patients that are combative and need to metabolize?
Dr. Kalinsky, your question was to SVMH and me.
I thought Nick Greenson was on, but he may not be on anymore. I was just rolling through the participants. I think he might have.
I'm sorry.
never mind.
I'm having some connectivity issues, but yeah, I'm sorry. Go. I can hear you now.
Oh, so Nick, they mentioned, and I wasn't even thinking this initially, but perhaps it isn't unreasonable. There's a large subset of these patients that are more, how should we say, meth intoxicated, combative, that really aren't necessarily behavioral health, and rather than needing behavioral health resources, need time to clear their intoxicants. And he was mentioning that this stabilization should be able to be done in any emergency department anywhere throughout the nation. What do you guys feel about that?
Yeah, that's fine. I mean, if they're not suicidal, if they're just agitated and delirious, we don't. I mean, those are patients we're fine taking care of. But the problem is these patients who clearly need to be on a 5150 hold. That then it becomes a lot more sticky for us. And there's a subset of those patients that with your behavioral health teams that you can clear and send home that we can't. Right. So that's kind of because I hate to have those patients in our ED where then they wait, 24 hours for a transfer and then get discharged a few hours later. I mean, that's just ridiculous. So, but yeah, for the acutely just, methamphetamine, acute, psychosis, delirium. Yeah. I mean, that seems reasonable to me.
So for AMR and the EMS agency, then what would you guys feel about potentially changing that policy? I mean, the clearly depressed, suicidal, non-flight risk, non-combative patient is a non-issue for us. And honestly, for both adolescents and adults, we're probably very well equipped, particularly as Ohana comes online. We'll be able to manage quite a few of these. There's a subset that it's going to be difficult no matter where you are nationwide. The patients coming out of their boarding care facility who are attacking staff, are schizophrenic, are not drug addicted, but can't be staffed or placed anywhere that are county attached, are going to be incredibly difficult for anyone. And honestly, my view on that is if you're in a borderline catchment area or, in proximity to both facilities, you probably should preferentially go to a locked facility. I mean, because that patient's not going to be managed outside of a locked facility, and they're going to be a transport for you. So you're going to be bringing your crews out again. But I don't know. What are your guys' thoughts as the agency? And maybe county behavioral health and a whole lot of other resources should be here and solving some of these issues, because the impact, again, that he mentioned nationwide on emergency departments is incredible, but it's starting to affect our ability to care for other patients significantly.
Right. So, I mean, good discussion. And of course, what you're observing at your facility is something that we're all observing throughout the country. These patients are resource intensive. They're potentially complicated because there may be dual diagnosis, often is dual diagnosis with substance abuse and psychiatric conditions. And it's hard to necessarily tease that out in the pre-hospital setting. Certainly patients who are, intoxicated and simply combative and not behaving well, I would agree that most emergency departments are capable of managing those patients. It becomes more complicated when patients have an underlying psych history and polysubstance abuse. And you're trying to tease out whether this is primarily psych or this is primarily substance. And the truth is that oftentimes it's a combination of the two. And getting those patients dispositioned from the ER is incredibly complicated, and figuring out which comes first is also complicated. It's probably not fair to put that on EMS to try to decipher which of those patients are appropriate for which facility. And so I think we probably need to be clear in having patients with psychiatric conditions who are psychotic, or certainly patients who are on a 5150 going to an appropriate facility, either CHOMP or Natividad, based on how close the EMS is to each facility and the drive time. I think both of those come into play. Of course, there's always going to be that, middle ground in terms of like, okay, we're equidistant from both, and so which one is preferential, and I would leave that to EMS discretion based on their drive times. Certainly, I do think it's potentially problematic to transport a patient who is unstable, combative, additional distance to get to a specific. For example, if they were picked up in Monterey, to drive across county to CHOMP to Natividad when the patient is combative and difficult for EMS to manage. And frankly poses a risk to the pre-hospital staff. Those patients, I think are better served going to the closest facility that has psychiatric services. And oftentimes those patients, once they're detoxified, so to speak, they can be cleared and potentially discharged. And if not, of course, then they fall into that problem with which every ER has to deal with in terms of disposition. I would be curious, I guess, for Dr. Orchard and Natividad, how many of the patients that you receive who need to be admitted from a behavioral health perspective, how many of those patients end up getting admitted to your facility versus do you find situations in which you have to transfer those patients out to other facilities simply because you don't have capacity on your inpatient behavioral health unit? I don't know if you have any insight into that or understanding of that.
Yeah, I don't have the specific data in front of me, but I would say a fair amount are stabilized in the ED and discharged. And I could look it up and get back to you, but I'd say a lot more, majority are stabilized and discharged after multiple hours.
So it sounds like maybe the majority are stabilized and discharged without ever having to be admitted to inpatient psych, which we also see at our facilities as well, and that sounds like it's true for CHOMP as well. And of those smaller subset that need to be admitted, certainly you have resources there, but you also have limitations on your capacity. And so I'd imagine that there may be some cases in which those patients may need to be transferred to another facility. So to do a double transfer from to Natividad and then from Natividad to another facility, of course, isn't the best use of resources either. So yeah, kind of complicated issue, a frustrating and difficult issue, I think, for anyone who's trying to manage these patients in the ED, and not one that is readily available, in which there's some easy, low-hanging fruit answers that we can all kind of just get on board and solve the issue without too much grief. But I appreciate, Dr. Klinsky, I appreciate you bringing this to our attention. We'll look at data as well from the system standpoint and see how many of these patients that you're managing at CHOMP, for example, are being ultimately needing to be transferred to Natividad. And what percentage of those patients are requiring that, and ultimately what the disposition is.
I think we can answer that already, is Natividad almost universally takes no interfacility transfers from us. And the majority of these patients, again, unfortunately, we'll have a crisis stabilization unit that can take care of the people that are going to metabolize over 12 to 18 hours. The bigger problem is the fairly significant number of people who are taking at least 3 days to a month to become stabilized or find appropriate placement and do not have a locked facility available. And again, are coming from county-based kind of mental health resource utilization in the outpatient setting and are very difficult to place and manage. And there really is no place, because Natividad, again, frequently, like you guys mentioned, is stabilizing and fairly full in and of them, in their own system, just like it is everywhere else. I think the goal and the point should be, though, particularly for those in between catchments, to try, if from AMR's perspective, that they're going to be combative, you have them in restraints and they're a primary psychiatric issue, probably the preference should be to drive towards the locked facility. I'm not saying take an unstable patient who's combative in the back of a rig from Monterey. Actually, I wouldn't even take that patient from me. If they're unstable, they're combative, and your medics are at risk, those patients should go to the closest facility. That's a true emergency, right? If you can't stabilize them and get them controlled with the Versed and have your medics safe, they shouldn't even divert to a psychiatric facility, because it's just an unsafe setting. Those patients really should be managed at the closest facility and stabilized. And again, those patients that appear to be purely chemmed up probably shouldn't be put on the hold in the field. They probably should be determined to not have medical capacity. There's no underlying psychiatric issue identified, and they're just combative and crazy. I mean, for alcohol, they do a really good job, but for drugs, we aren't necessarily the best. And a lot of them end up on holds for unclear reasons, but those can probably be managed anywhere.
Hey, Dr. Burley, if we could hear from Michael from AMR, and then looks like Chief Nieto has her question up. And then just for the sake of time, we've got about 26 minutes left.
Okay, thank you, Jesse. Sure. So AMR, any thoughts from your standpoint?
Yeah, I was just going to comment. I think that, for the most part, everybody covered most of our concerns. From a general aspect, I think that we're advocates, obviously, for transporting the patient to the right facility the first time. Most specifically, the patients that we find that if we do transport to CHOMP, for example, that, inadvertently within a few hours, we're transporting them to Natividad. But I would ask, along the same lines of what you've presented, is that, I do think that there needs to be some greater study that would take place, especially in cases where, remember that our caregivers, there's usually just, one individual in the back with a patient. So creating a longer transport time with a potentially violent patient also could put them at risk. And then also the impacts of the system, in a broader picture, meaning that, even if, the most appropriate facility or all of these patients are being transported to Natividad, you're going to end up with longer transport times and then, potentially overwhelming that facility where now you're increasing, APOT times and taking away resources out of the system. So we're certainly advocates. I mean, I don't want to say that, we would be opposed to doing that. I think that, making the decisions from the patient standpoint, obviously, is the best, the best position. But, I would just ask that we do look at those and take kind of a greater, study those transports a little bit differently to make sure that we're not creating other, squeezing a balloon per se, where solving one problem and creating another. So thank you.
Great, thank you, Mike. And then Chief Nieto, you had a comment?
Yeah, just real quick, I have to log off. I have some other meetings to do. Just to let you know, for the other meetings that we have today for all the medical stuff, Keith Boyd will be on, Chief Boyd from King City, as the representative for law. Thank you, Teresa, and thank you, Dr. Burley. Bye, everybody.
Thank you, Chief. Okay, well, again, thank you for bringing this topic up for discussion. I think this has been a pretty good discussion of where we are currently and some of our concerns and challenges. And we will continue to take a look at this. We'll pull some data and take a look at it from a system standpoint to try to determine what serves patients best and also what's amenable for this from a system standpoint. So thank you all for good discussion, and for the sake of time, we'll go ahead and move on to the next item on the agenda under new business, which is MCRFD EMT Expanded Scope Program. Steve Brooks has something for that.
Yes, I do. The EMS agency has received an application and supporting documents from Monterey County Regional Fire District to provide EMT expanded scope services within their district. Monterey County Regional was aggressive in getting the materials to us. The EMS agency had hoped to be able to have everything together in time to bring this to MAC as part of the process in our policy for endorsement of that. But we find that we are not able to bring that forward at this time, and we'll be bringing it to this committee, we hope, in January, with the whole complete packet ready to go for MAC to review and potentially endorse. So at this time, we're going to ask that this be tabled, and we'll bring it back for January.
Okay, thank you, Steve. The next item is AB 361, requirements for remote meetings. Jesse, that's yours.
So just a couple updates. I think we need to vote on this to confirm we want to continue meeting pursuant to AB 361. That would put our next meeting date as December 7th at 8:30. There'll be another one, I believe, on January 4th, and then our next MAC is a few days after that. So we'll have two AB meetings within that. There was a notice from Governor Newsom that came out a few weeks ago, essentially ending the state of emergency effective February 28th, 23. So I'm not sure how that impacts AB 361. We do need a motion, though, to continue meeting AB 361 wise, and we'll entertain that now.
Counselor, I'll make the motion to continue under AB 361 for remote meetings.
Okay, thank you, Jeff. We have a motion on the floor to continue meeting under AB 361. Do we have a second?
This is Ben Hitchcock. I'll second.
Oh, go ahead. Ben.
Sorry.
Second,
I'll second that motion.
Jesse and Ben. Okay, thank you all. So let's go ahead and do a roll call vote on this, Jesse.
Very good. I'll get a Ben and Christy for tied for second there. Roll call. Dr. Kalinsky,
Aye.
Dr. Hawthorne,
Aye.
Dr. Orchard,
Aye.
Dr. Greenson,
Aye.
Christy,
Aye.
Carrie Campman,
Aye.
Ben Hitchcock,
Aye.
Jeff Horner,
Aye.
and if Chief Nieto is still on, or Chief Boyd. Okay, hearing none. Thanks, Doc.
Okay, thank you. So the motion carries for us to continue meeting remotely under AB 361 requirements. So let's move on then to EMS System Quality Improvement Program and CQI tag. Deborah and Blake, you have that.
Yeah, I'll go ahead and handle that. We are beginning to work on transferring the primary responsibility for the CQI tag group to Blake. So he will be providing future updates and coordinating those meetings in the future. For now, we recently completed meetings of the STEMI stroke and CQI tag groups. The TQuick meeting was postponed for a variety of reasons, including Natividad's re-verification site visit for their trauma program. So the primary news from the STEMI and stroke groups were that they were able to review the outcome and follow-up data through Get With The Guidelines for the first time and had that data presented. So they're continuing to refine the points that they're looking at, and more will come on that. As I mentioned, Natividad recently had their re-verification survey. The EMS agency completed throughout that, was involved in that process throughout it. They had their closure interview and had very positive feedback during that interview. So good news from that. And I will also add, as Steve mentioned earlier, that the CQI tag group is starting to look at resuscitation and cardiac arrest treatment and management within that group. So more will follow on that as well. The upcoming meeting dates are included in your agenda packet, and happy to answer any questions if there are any.
Okay, thank you, Deborah. That brings us on to any future agenda items, any items that anyone would like to see on future agenda for MAC. Okay, hearing none, we'll move on to announcements and go to the order. Any member of the committee may make announcements or comments. MAC may not discuss or take any action on these items. Any items for announcements or go to the order? Okay, well, that brings us to our next meeting date. So the next special meeting of MAC is to reconsider AB 361 remote meeting requirements is tentatively scheduled for Wednesday, December 7th at 8:30. And the location and Zoom information will follow on that. The next regularly scheduled MAC meeting is scheduled for Wednesday, January 11th in the new year, 2023 at 8:30 a.m. That brings us to adjournment. So thank you all. Appreciate your time, and we'll look forward to seeing many of you at EMCC.